Hello, I'm Dr. Steve Karstensen, Chief Dental Editor of Dental Sleep Practice, a Medmark publication. Welcome to an educational presentation and Q&A with Dr. Erin Elliott. In our webinar today, we will discuss oral appliance therapy and complex dental presentations with a focus on clinical cases and quite a bit on edentulous cases, something you don't see anywhere else. Associated with this presentation is a free CE quiz. At the end of the webinar, we'll email all the registrants the presentation recording along with instructions on how to access the CE quiz. Before we get started, I would like to invite everyone to use the Q&A feature in the control panel to ask any questions. I'll get those to Dr. Elliott as time permits at the end. Dr. Erin Elliott is a highly accomplished dentist based in northern Idaho with expertise in dental sleep medicine, short-term orthodontics, all forms of primary care and restorative dentistry, and integrating CAD/CAM and cone beam imaging into general dentistry. Originally from Southern California, Dr. Elliott earned her undergraduate degree summa cum laude and graduated in the top 5 of her class from Creighton Dental School. An active member of the American Dental Association, American Academy of Dental Sleep Medicine, and other organizations, she regularly lectures and teaches 2-day sleep apnea courses with 3D dentists. Passionate about educating dental teams, Dr. Elliott offers private coaching and helps practices implement sleep apnea treatment and digital dentistry in an engaging, practical way, as you will soon see. With her energetic and approachable style, she strives to make a difference in patient care and practice success. Thank you so much for joining us, my friend. Now I'll turn it over to you to learn more about today's topic.
Thanks, Steve. One of my favorite people in dental sleep medicine, and I'm excited to be here because one thing that I do when I'm teaching is I say there's no other appliance that can help you in edentulous or partially edentulous situations like SomnoMed can. And so I'm going to kind of share, there is some extra steps. You know, it says oral appliance therapy in complex cases. I don't consider it complex. I just think that there's just some extra steps involved that most people don't know about. And I'm hoping by the end of this that you will not be as concerned or scared of treating patients with dentures, partial dentures, or even edentulate areas. And as Steve said, I am still a practicing dentist, and I get to do dentures and partials and extractions and all of those things, and I see compromised dentition all the time. Now, I also oftentimes have to put my handpiece down and put my stethoscope on, as I say, when I'm treating sleep patients. Now, people with compromised dentition don't often, have the epitome of perfect dental health. And as long as they have, pretty stable dentition on the lower, or even no dentition on the lower, we can help them. I just want to, this disclaimer essentially says that it's not that SomnoMed advocates for this. Some of these things I've kind of just figured out on my own. They do talk about having at least 4 to 7 teeth on the lower, but I've experimented with doing this for fully edentulate lower arches, and you'll kind of see how we navigate that. Oftentimes, though, what is the first thing that hygienists tell patients with full dentures? To take them out when they're sleeping. And you'll often find that patients don't always listen. And sometimes it's vanity. I have women that tell me, oh my gosh, my husband will never see me without teeth. He never has, and we've been married 40 years. But I think, and they're not always able to articulate it, but they sleep better with their dentures in. And that's because they're not overclosed and their airway's not compromised. So they sleep in their dentures, and I don't get mad at them. The concern for taking your dentures out is that you don't get a fungal infection. And as far as I know, I haven't seen, death by oral fungal infection on a death certificate. Lack of sleep and lack of quality sleep and OSA can certainly compromise health more. But saying that, I just ask them, please take them out during the day when you're at home. No one's there to see you. We need to give that tissue time to heal and rest. If they're CPAP intolerant and don't have teeth, what do you do? I mean, really, we're telling them to go without treatment. Now, I know we have Inspire now, and that may be an option. But of course, that's surgery and a big step and approval and all of those things. And then we do have the tongue retaining devices. But as far as I know, my experience, the people actually doing a tongue retaining device is about 0%. So maybe there's a few out there. But if they have unstable dentures and they have a problem wearing CPAP, what can we do for them? Well, I will say that we do need to have at least 2 implants. I have made back in the day, probably 2013, one oral appliance on full dentures, but they were pretty stable lower denture. And it was at a time where I was like, well, it's like 50-50 chance that they can wear this. We have no other options. And their out of pocket was $0. So I felt like we could kind of take a chance, but that's just something I won't do anymore. Another thing I won't do anymore is make full dentures without at least 2 implants on the lower. Because not only is it terrible for the patient, but it becomes a headache for us. I don't want to make adjustments every other day, and I don't want them coming in and saying they want their money back because they can't wear it. I mean, really, we warn them that these are not a substitution for teeth. It's an alternative to having nothing. But for some reason, they have it in their head that they should be able to use full dentures like their teeth. So what we do in my practice, for example, I had a patient come in fully dentulous, and she came in for sleep. What you're seeing here is a cone beam I took. She had been fully edentulous for many years, but she was desperate for sleep and tried CPAP and was in tears like she really wanted it to work and didn't know what else to do. So the good part about my practice is that I place implants. And this is, you can see the radiographic markers of her lower denture, and that's because we did a soft tissue borne guide. And it's a very simple procedure. We just punch the tissue out, place some implants, let them integrate, and then I lock her existing denture on and pick it up so that she has some stability. And the nice part about that is it's all under one roof, but we were able to keep the cost down because she didn't have to buy new dentures because, she is on a limited income. We were able to do 2 implants for her, make it affordable. And again, making it affordable is a lot different than saying it's expensive. We do have different payment plan options. As soon as dentists start speaking consumer language, because that's how consumers think. Think about even your own car payment. Do you know how much your car actually costs, or do you know what you pay every month? So we kind of speak in that way, what can you afford? And let's get you the dentistry you need so that we can also help you sleep better too. And it was tickled to death. The day we locked in her dentures, she said it changed her life. And then we went on to help her sleep better too. So I always, always, always recommend SomnoMed. It's something about that patented soft liner that just fills the gaps where there's no teeth, and it fits well. They do have a acrylic base as well, but I'm just such a sucker for that B-Flex comfort liner. And I have a friend in Florida that is a Medicare provider and does only dental sleep. And as you know, or as he teases, is that Florida is God's waiting room. And he has to make a lot of these SomnoMed appliances with dentures. In his experience, was making them over the upper dentures themselves. And I've done that a few times, and every time the patient who's had their upper denture for 40 years, and now we're putting the basically an appliance over it, gets pressure points right here. And one time my assistant went and adjusted that pressure point on her 40-year denture, and it never fit the same again. So please do not make that mistake. What I recommend instead is taking the upper denture out and replacing it with the appliance that's similar in size and shape. And so you'll replace the entire upper with the oral appliance itself. And it's similar to an upper denture. You're going to make sure you have the vestibules, you have a good impression of that, and a palatal seal, and it really is retentive. I don't think it's a mark of failure if you need to use denture adhesive. For the most part, we don't have to, but there's times that the ridges are just flat. If they've been edentulous for a long time, there's not a whole lot to hook on, and you're reliant on the seal. But if we have to use some denture paste, I don't think that's a big deal at all. And oftentimes the patients are used to it anyways. But the way, if you think about the way that somnamids are designed, especially in the dorsal fin type style, it doesn't pull down on the denture, so you're not breaking the seal. If you have a good seal on an upper denture, how do we get it off? I know I tilt up to break the seal and it comes off easily. So if we had pressure in that upper anterior or torquing forces, it would dislodge all the time. So instead, the way that the pressure is basically holding it back on. And that's why we see those pressure points right in the canine eminence. So this does not allow for the pulling down while still advancing the lower jaw, and it stays so that we're not in that battle of it coming off. So I do prefer the B-Flex Comfort Liner. The dorsal fin design is great because of where the pressures are in the advancement. But of course, oftentimes we're stuck in PDAC world, which is totally fine. So we'll make a Herbst for them and it works just as well. A lot of that pressure is in a similar situation. I just don't like the Herbst because it can drop open so much easier. That's where we use elastics. So we'll kind of have to play with that. Or oftentimes, if the elastics are kind of pulling and the jaw's dropping open, then we can always use lip tape. And for some reason, there's been a switch in my patients so that when I recommend lip taping, they don't think I'm crazy anymore. And there's all sorts of different styles. Just even 3M micropore tape at a vertical. Myo tape goes around the lips, so it's not like we're, putting it over so they can't breathe at all. But with the Herbst Advance Elite means that it is CAD/CAM milled and from a very strong material that's in a puck. But I have had it once where the upper arch was so large that they couldn't get a full upper oral appliance from it, and there was like a horseshoe shape in the palate, and we just didn't get that seal. So if the puck is large enough, or if the maxilla is small enough and the puck is large enough, then I go with the Elite. If it's not, no problem. Herbst Flex, it's very strong too. It's just a little different material. And this is from Somnamid. The patient requires at least 4 to 7 quality teeth in the lower arch. But I'm not one to follow all of the rules, and I want to get my patients the help they need. So that's where I've experimented with the fully edentulous mandibular arch and had success. In this picture, this is a patient. You can see the upper oral appliance replaces the maxillary denture. And it's a dorsal fin design, so you can kind of imagine the pressures are back on the maxilla and they're pulling the mandible forward. I would not recommend making it over the partial. A Somnomed, the B-Flex is effective enough that if you have any sort of teeth on the lower, take the partial out, it'll have enough retention. Reason why I say that is most patients who are edentulous aren't edentulous by accident. And where the partial and the tooth comes together, as you may know, is very susceptible to decay and breakdown. So even in this case, you can see the like plaque and buildup where the partial and the tooth fit. So my recommendation is not to make it over the partial because I think it's a hygiene hazard. And if you lose those teeth, then you're in a whole nother situation and downward spiral. So take the partial out and make it over what teeth are left. The upper edentulous splint covers the palate, like we said, similar to the denture. They can still open their mouth, and the retention is there, and we can see where there's sore spots. I'll kind of go through how we adjust for those. If there are any sore spots, it's usually right in the canine eminences. I know there's a lot of writing on here, but I wanted to make sure you had all of the information in a clear and concise way. So again, we cover the palate, we want suction, there's no downward pull. We SomnoMed says there's a minimum of 4 to 7 quality teeth, but if we use edentulous splints, we can make it over the implants themselves, and I'm going to show you both ways, or over the full lower denture that hooks onto the implants. Kind of your choice, patient's choice, you and your lab's choice, but you'll see both ways. So to begin, I do take a series of impressions. The way that we do it in my office is usually over the lower denture with at least 2 implants. If the patient doesn't have lower implants, then we offer a low-cost way for me to do that. Yes, it puts a stall for 4 to 6 months, but it also helps them with their everyday dentures. So we take a upper edentulous impression, the best upper full denture you've ever taken. We need to get the vestibule so that we have good retention there, but we also have to get that hard, soft line. So you need to make sure it's posterior enough that we have that. So I have patients kind of puff their cheeks. I practice beforehand and kind of like massage the material around to get it all up there and kind of a functional impression. And I make sure they kind of go, because that finds that hard, soft line. And we want to make sure that we have that recorded. I love, and this is, I was not paid for this, but I love the Kettenbach so much that use whatever you normally use, but the putty and wash from Kettenbach has provided us just such great, not just detail, but the cost is good. And with the putty, you're not wasting a bunch of PVS. You don't get the pulls and drags like I used to. So we'll send that impression to a local lab to make wax rims. Now the lab finally figured out that I was just making wax rims and not full dentures for these patients, even though I kind of gave them a heads up. So I'll pay a local lab to make me a wax rim because SomnoMed doesn't make those, but they don't need to. That's just a whole lot of mailing back and forth that isn't necessary. But what I also do is I include just a Silginate outside the mouth, Silginate, alginate, whatever something, some cheap material. And I take an impression of the upper denture. And that is so the lab knows what they have existing so that they can make a wax rim in a similar vertical and a similar width so that I don't have to do a lot of adjusting when it comes back. So then it is pretty straightforward. If they have a dentate lower arch, we take a polyvinyl impression. I'm sure you can scan and all that, but we do everything by scan. But when it comes to the dentures, I just go back old school analog. There's a few times that I will use analog, and this is one of them. So we take an impression of the lower arch, make sure you get to the retromolar pad because that's where we'll get some of our retention and stops. And then if they have a fully edentulous lower arch, we have to decide if we're making it over the implants or over the lower denture hooked onto the implants. So we'll take an impression of that as well. So when the wax rims come back from the local lab, I'll take a protrusive bite with the wax rims in place. Now, that base plate that they have is not very retentive. And so I always warn the patients that this is not how the oral appliance is going to fit. This is nothing like the final product, because when it like falls out, I don't want them to lose confidence in this. The first thing that I do is try it in and have them bite into place to make sure the wax rims are even, that we have the curves of stay correct, and then I mark the midline of the face, not necessarily the midline of in relation to the lower arch. So midline of the face, because that kind of helps me place the fork, but also is good for the lab techs. And then SomnoMed can go from there to make the final oral appliance. So this is what the order form looks like. There is a place on there that talks about Edentulism. If you need any help filling this out, SomnoMed customer support is awesome, and they can certainly help guide you as well. So you make sure you're ordering the right thing. One thing that I always, because I normally have to go with PDAC, I'll ask for the Herbst Elite, but I will make a note there that if the puck isn't large enough to get a full palatal seal, then we'll go with the regular Herbst. So when it comes back, again, you want to look for sore spots. We have the patient put it in for a while, 5-10 minutes, because I want them to first get used to it. But we do try to warn them that this is not like their denture. Most people with dentures for a while, it's like an old pair of shoes. They've learned to work around any, I don't know. I see people with loose dentures all the time, and somehow they've learned to stabilize it. They adapt to it really well. So this is like putting on a new pair of shoes, and I warn them they may have to break them in, right? But if there are any particular sore spots, my favorite way to adjust for them is with Hydent. You can use traditional pressure indicator paste, but the way that this goes on so uniform, it shows those wear spots so beautifully, and it cleans up really nice. So again, usually the sore spots are in the vestibule if they're not used to having them so high, as well as the canine eminences. And I just use a regular acrylic burr. It works great. And then we just kind of make sure that there's no sore spots. We tell them that they can use paste if they need to, or denture adhesive if they need to. And just to kind of have a few nights, we may follow up a little closer than we do our traditional oral appliance wearers, just to make sure they're comfortable and also not giving up. So again, this is what I choose from based on the size of the palette. And I do always go with the B-Flex liner. There's just nothing like it. It doesn't peel, it doesn't get all icky. Sometimes there are patients, you guys know what I'm talking about, that it's disgusting. Do you ever clean this? However, I just feel like with that liner, it just never gets grody. So if we want to make it over the implants themselves, this is a case by the legend, Dr. John Tucker, who also works in a town similar to mine, where we do see a lot of edentulous people. And I do believe he places implants too. So a similar situation where we can help the person with their everyday dentures as well. But what you'll notice the difference here is that the lower is made and snaps into the implants directly. So the way that we do that is an additional bite rim for the lower. SomnoMed will make it, and then we lock in the housings in the mouth, directly in the mouth. So there's the implants in place, and male versus female parts, we kind of refer to them as. And so the lower denture fits into those lower implants. And we can take, to share with the lab, uh, we can take impressions of the lower arch, edentulous lower arch, but also the denture that they wear so that they can make the wax rim in similar size and height. So we have good edentulous impressions and models. I don't pour the models. I usually send that to the lab to do. They have all of the machinery to make them really like non-porous and do the bases and all of that. I gave up on lab work probably in 2004 when I graduated. We send them to the lab for the bite rims. And then I do send impressions of the dentures for reference on vertical and arch shape. So here's the wax rims coming back. Now I've noticed that my lab does not make these little wedges. So I have to make them myself. I use an old school buffalo knife, and you'll see why we need those little markers in the wax rims. And that's so that we can communicate with the lab really nicely. So hopefully your lab makes these, but there's times I have to make them myself, especially if I'm kind of cleaning off the wax rims. So oftentimes they're a little high in the posterior, so the wax rims are hitting just in the posterior. So I take the buffalo knife, peel off some of the wax layers on the upper and lower so that it's fitting evenly. And we can compare it to their existing video with the dentures in place. So with the dentures in place, you can make a mark on the nose and the chin. I use a dry erase marker now because we'll do Botox and stuff in our office. And so the dry erase marker, it comes off so nicely. And I used the eyebrow pencil thing before, and you kind of have to dig it in to make it actually color. So the dry erase marker is just a boop and a boop. And I have them do that when they're biting down in their existing dentures. And so you want to make sure the wax rims are similar. Now, do we need to have the exact same video? Not necessarily, but we also know that's what's comfortable for them. Do we want to open them up more? Maybe. Um, if they're worn down or anything, but I just try to stick with what is comfortable because the patients are adapted to that. So we can also look at the wax rims to make sure that it follows I have the patients look straight at me, and I want to make sure it's parallel to their pupil line. And so we can make sure the wax rim isn't high on the right and high lower on the left or whatever, that it's even with the interpupillary line. That's the box plane. And then with the wax rims in place, we'll make sure the video is similar. So I just use a good old-fashioned buffalo knife. You can see this is coming together very nicely. You can also see these little notches in here, and you'll see why we need those in order to communicate with the lab. The only thing I do in addition here is mark the midline of the face. And then I'm going to talk about SOMGauge real quick, but you'll kind of see that I don't always use that in the wax rim situations, but the SOMGauge is like it has changed everything for me. I don't know how I got by with George Gauge for so long. But the SOMGauge is amazing. And what makes it different is the fact that we can adjust the vertical so easily. There's all sorts of other gauges and gadgets out there, but this is straightforward, easy, and I never ever get those calls from the lab now that I don't have enough vertical. And the nice part is I don't have to worry about my assistants melting it in the autoclave. Um, and there are times, it's not all the time. I know traditionally I try to keep the vertical low so that we can get a lip seal. That's very important. Nasal breathing, lip seal. But I notice in men with vaulted palates or scalloped tongues, kind of those really loud snorers, I do test the vertical. I test the vertical. And the SOMGauge allows me to work with that. The fork itself is single. I mean, they're not expensive, so you can use a different one for each patient. Because I scan most of my dentate cases, I do just go with a small, because if I was using bite registration all along, I'd want to capture the cusp tips, so I would change the side. But because we're scanning, we just need to capture the buccal side. But what it does, the bite fork itself is 3 millimeters. So we can make sure that all the way to the posterior, we have enough room. Meaning, is there a super erupted tooth or a weird curve of spay that even though the vertical set at 4, it's not 4 all the way back, because of course our jaw is on, we have more of a pivot, right? So then I increase the vertical to make sure that we have clearance all the way to the posterior. Then I don't have to adjust. I don't know if you've used a George gauge in the past, you always have to adjust the upper incisors where they fit. This one fits every time. It'll take crowded maxillary anteriors, it'll take worn and thick cingulums, and all they have to do is bite in. There's really no adjusting there. The handle's really nice. I can see the numbers. So it has really been a huge advance from the George gauge, and I really love using it. So here's what makes it different. So this screw here loosens so that you can adjust this ramp. So if you can imagine, if the lower anteriors fit right in here and the fork slides in here, what this would look like when it's all put together. So the upper incisors kind of hit up against this vertical wall here, and they just slide right down this ramp. That's why there's no adjusting for different sizes and thicknesses of upper incisors. This fork you can see is pretty hefty. It's the 3 millimeters, so that we know we have clearance all the way through. Now, if we want to add vertical, I will just loosen this screw and then we move the ramp up. So if you can imagine, this ramp is now closer here. The upper incisors are not going to come all the way down. It's going to be stopped in this area first. So we have essentially increased the vertical. And then I'd have the patient go forward as far as they can, back as far as they can, and we take a certain percentage of their range of motion. And then I kind of play with that. I'll have them do a snore test where I have them snore. And then I have them go to, let's say, 60% and see if they can still snore. And then I'll move up to see if the vertical seems to help, and I'll go way protrusive just to see if that snoring goes away completely. So we just kind of play around to find that sweet spot of a starting position. Starting position does not mean the snoring has to go away fully. Starting position is where their muscles are relaxed and their airway is on its way to being open, and we may need to advance the appliance from there based on their need. But when it comes to taking a bite, a protrusive bite with the wax rims, We don't need that vertical. I kind of mush this George gauge, a 2 mm George gauge. This one shows a 5 mm, but we usually have to take away that part that sits behind the incisors so that we can dig it into the wax rim. So here we are. That's where I have the midlines marked, is so that I can line up my fork with the midline. You can see that midline is missing. And then that's why I put the wedges in the wax rims, is so if it comes apart, it only has one place where that bite registration and fork will fit. So I essentially secure the gauge to the upper denture first, lined up with the midline, and it has a little gouge. I'll show you in the next slide how I get it to fit all the way down flush against the wax rim. So you can see these little notches here are ones that I created in the wax so that the lab can line it up perfectly. So I know this is a little messy, but this is my life. I don't love lab work. Okay, so here I made these notches. You can see I probably cleared out some of this posterior. So even if my lab made these notches, I would have to remake them and make them really nice and pointy. I also have this kind of gouged out, and that is so that bite fork, this little part here, you can remove, or I just remove some wax to kind of wedge it in. I had the bite registration material in these little X's here, or my little triangles that I make, my little wedges, and secure the gauge to the upper denture. Then I can have the patient kind of go through the protrusive measurements and see where we would like to start them. If you're doing the fully edentulous version, then you would secure the gauge to the lower part of the anterior. You may want to thin it out, but of course you can adjust for that in the gauge itself. So we'll look at the protrusion, come forward as far as you can, come back as far as you can. Because this little screw here is loosened, they can move the fork, and then we lock in the screw where we want them to start. And then we take the bite registration for the lower arch. You can see we kind of goop it up to make sure we have it captured, and so that the lab can recreate the bite. Then when the appliance comes back, we put the housings over the implant and adjust where it might be binding if needed. And again, that high dent. And I really gouge out these because I don't want it, because the housings obviously are a little larger, the female part, we're going to pick them up into this lower dent or appliance. We need to make sure there's no binding of that housing at all, because we need the pickup material to be fully around it so that it is retentive and it adheres. So the locator housings have to have clearance, and that's what we can do here. It passively sits, and then we do want a little escape route for that material so that it doesn't escape into and around the abutments. And then we bond to that so that the pickup material will adhere and not come loose. And you can see we let it set, clear out any excess from the vent holes, and kind of clean up around the housings. Now these housings that are in here are passive so that it comes off. Once it's all set, make sure this is set. Don't try to peel out this plastic before this is set. We'll peel out the plastic, and then we can put the more adhesive rings in there, the tighter rings, so that it stays. So clean up all the excess. Looks beautiful. We'll take out that black liner that's more passive so that we can replace it with more secure. So here it kind of looks on the models. Looks beautiful. And then here's one of my cases. You can see that I'm making it over the lower denture here. We have a good impression of the upper edentulous arch. Here's the wax rim. You can see here's my midline that I marked. I made those little sharp triangles so that the lab can recreate the bite. And also the B-Flex liner is it just hugs the teeth. Like it really is beautiful. There are times if the teeth are really worn, the one thing that dentures don't have are embrasures. So I used to make, I don't know what I was thinking, but I would make dimples kind of all along the denture, and I was like, wait, the appliance doesn't even go that far down. The key part is the gingival embrasures. So if those are not very defined, I'm going to make them more defined. The patients won't notice, and I do explain why, and they're usually more than happy. And it's more in the posterior. I don't really mess with the anterior. So in the posterior regions of the lower fully edentulous, denture, if I'm making it over the denture, I will make deeper gingival embrasures. And that is about it. So hopefully, the next time you have an edentulous patient come in, you don't have to turn them away. And I actually had to get the message out to physicians as well. My referring physicians, what I tell them is even if you're unsure about their dentition or anything, just go ahead and send them over and we'll make that determination. Now, it's not a standard question we ask over the phone. So there's times that maybe this consult is quote unquote wasted, but not really, because that's an opportunity for us to discuss implants. It's an opportunity for us to kind of get their dentition in order. I don't do a dental exam oftentimes if it's not my dental patient. And if someone has like a broken cusp, and let's say we're making they have some teeth on the lower and they have a broken cusp, I ask them how long it's been broken, usually years. Does it bother you? No. Are you ever going to get it fixed? Not really. So I don't make them have perfect dental records before I'm going to treat them for an airway sleep issue. That's where I said you put the handpiece down and put the stethoscope on. And when I do my exam for sleep, I'll say, and now I'm going to go ahead and take a look in your mouth. This is not a dental exam. I'm not looking for cavities. I want to see what things are contributing to your problem and which appliance should be made. So if I see a broken cusp, it's not necessarily going to stop me. If they have missing teeth, we may talk about future of implants, but if they haven't already started on the implant path, then that's like a whole nother year of waiting. So I'm like, I want to treat the more immediate issue, which is getting oxygen and getting sleep. So hopefully this helped you not be intimidated by edentulous cases. They don't come along like terribly often, but enough that we are prepared with impression material and all the right things to make sure we can get our patients help.
Thank you very much, Dr. Elliott. That was so thorough and so practical. Really appreciate that. We do have a couple of questions, and one of them actually occurred to me as well. Is if you have that case you're doing, and they're wearing a lower removable partial denture, so they've invested quite a bit of money in that partial denture. It's got a framework that has a precise fit, and you're going to make an appliance that puts forces on the teeth to hold the jaw forward. Are you worried about the fit of the partial? And if you are, what's your conversation with your patient like as you're going through this process?
I really am not concerned about that just because I haven't seen tooth movement in so long. The only time I see tooth movement is if the distal of the mandibular second molars aren't covered. because it kind of moves as a unit, right? The forces are bringing we want to make sure the entire unit is brought forward. So as long as we have a well-fitting, even with the flex liner, I do sometimes see teeth spreading apart with ball clasps. So another reason why I like the flex liner. As in everything, it's informed consent, right? I don't see as many cast metal partials, to be honest. I see more of the Valplast type partials, which I don't like. I just see such a better fit with the cast metal, and we can add teeth in the future. So, I may say we may need to make some adjustments. If you see any changes or your partial's not fitting as well, please let us know. One other thing you can do is go to their original models. I go to where they started and either 3D print that or have the stone models available. And you can make almost like a suck down retainer to that. So in the morning when they wake up, they put a retainer on and just make sure everything is kind of back to where it needs to be, if there's any concern about that at all.
Yeah, that's a good one. Yeah. And then you mentioned about patients getting used to the fit of something new after wearing a denture for a long time. Well, we all know about how many nerves are dedicated to sensations from the oral cavity. And so our brains get, kind of programmed how to make things work and how to make things fit. When you give them something like this, do you ever use like oral malfunctional therapists to help them get used to something new like this?
That's a great thought. No, but now I might.
Yeah.
What's amazing to me is sometimes when we have denturists in our town, in our state, so I don't see, like, I don't have to make full dentures like ever. The only time I do, I will only make full dentures. I will make full upper, no problem if I'm doing the surgery, right? But I will only make lower dentures if you have at least two implants so that I
Mm.
don't have to deal with ill-fitting dentures. But what's amazing to me is how many fully edentulous patients I see with hardly any bone, and they have been wearing their dentures for 30, 40 years. And it is them adapting. And the upper, I'll tell the patients we rely on the suction from the palate, but the lower is you training your tongue to stabilize them. Myofunctional therapists are physical therapists of the tongue. So it does only make sense to help them adapt to that by making their tongue stronger and training it. So I do have a myofunctional therapist at my office, and we've even started, I do look for tongue ties in my patients now, but oftentimes they don't have, if I were to do a release, they don't have the room. And my myofunctional therapist, we're kind of coming up with a limited myo training session for adult sleep apneics that may not be getting a release, if that makes sense. We're going to
Mhm.
increase tone and training to get it to the roof of the mouth. But that's a great idea with the edentulous ones.
Yes. And another question about the implants is somebody comes into your office, they have a full denture. You know that you're not going to place an oral appliance without two implants, but they're with a breathing problem now. How long do you wait after you place the implant? Say they say, yes, let's go. I'll have it done tomorrow. But how long do you have to wait to make your oral appliance then? And what do you tell them to treat their breathing in the meantime?
Well, most of them aren't treating, they've been going without for a while anyways. And that really, if they've gotten to me with the edentulous arches, they've already tried CPAP. You could try a tongue retaining device. There are a couple different ways though that you could. I do have friends that place the implants and lock it in the same day. I just really hate failure and I'm not willing to take the risk. So I do wait the usually 4 months because you can get good torque, and I bury it under the tissue so there's no movement, and do pick up after 4 months. Expose, pick up. Saying that, you could you could, if you're real concerned about this patient, place the traditional implants, bury it and cover it for 4 months. But in the meantime, you can place like 4 to 6 minis. And I've seen this done quite often where you place the minis and you can move forward because if you miss, they're really made to be temporary. And if you lose a couple, you'll be fine. And it gives them stabilization in the meantime. Because lower dentures you can always reline. Even the oral appliance you can reline down the road when you're ready to pick up the traditional implants.
Well, that makes a lot of sense. So it continues the thing that you and I always know is that you have to think your way through each one of these cases.
I
You know,
love problem solving, Steve. It's my motto is figure it out.
there we go. That's right. I've heard you say that many times. That's right. Hey, one of the things you talked about the starting position, and I was at a conference not too long ago, and Mark Bream from Belgium was talking about maximum comfortable -2. Were
I
you
like
in
it.
that lecture
I
at
was
all? Okay. So what he talked about, and as you said, there's not really a solid bunch of science that says go here as a starting position. So what his study showed that he had him slide back and forth on the gauge, and then he would just say, okay, find your maximum comfortable position. Comfort meaning something that you emphasized, and then just subtract 2 from that, and that's a good starting place. And so you're likely to hit a comfortable place to get them started, and then who knows if you're in an effective position. We never know anyway, right?
well, exactly. And that, I mean, we have more and more tools to measure at night while they're wearing the appliance, faster than or more than just one night. Talking about some, gauges inside the mouth or recorders. But saying that the starting position, I never give a set number. It depends on their severity. But also I look to see are their jaw muscles loosey-goosey and happy, or are they tight and constricted? So the range of motion and the severity and like there's so many things to come into play. And this is based on the old Matrix Plus studies, but they have a great graph that shows where people were treated, and most of it was outside of the 50%. Of course, there was more milds that might have been 40 to 50%, but most of them were stretched out, especially the more severe you got. You needed to be more like 80%. So I might get a little bit more aggressive on the starting position the more severe they are. And I always tell the patient, this is the starting position. We want you to be comfortable. We want you to get used to it. But just like just like I can't touch my toes right now, but if I stretched for 7 hours a day, eventually I could. And so your muscles of the jaw are the same way that as you wear it, your muscles will relax and adapt, and you'll be able to move forward more comfortably if we need to.
There we go. So it's and so that actually speaks to the next question, which is about how often do you see patients that are edentulous? So is it more often than your patients with their, more dentate and pretty straightforward for appliances? You
Yeah,
mentioned a little bit more oversight.
yeah, more just to make, I just have a I have a feeling as they're adapting to something new that's different than what they've been used to for many years, that I don't want them to get frustrated with sore spots. And so instead of the 1 to 2 week, maybe we see them a few days later and then a week after that. Not that I want frequent visitors or frequent flyers, but it may take a little bit more adapting, way more surface area too. But it's all, don't you know it, that if you adjust this spot, they're like, that feels great. And then another spot shows up. And so sometimes you are chasing a little bit, but that hide and spray, I think, kind of can get in front of areas before they become a problem.
That
But
is a
yeah,
good.
you'll want to encourage them that you're not bothering us. It's okay. It's a quick appointment, and I can have really it doesn't have to be my sleep person per se. My chairside assistant can do it. Anyone who can adjust dentures can do that.
There we go. Well, that's all of our questions that come in. So I really appreciate the time that you've spent with us here. Um, and I very much appreciate SoundMed for sponsoring today's program. Thank you, everyone, for your questions, but we've run out of time. Within an hour, we'll send you a link to the replay of this presentation and instructions on how to access the CE quiz. Please be sure to complete the free CE quiz associated with this webinar to receive your CE credits. Thank you so much, Erin, for being on this and spending your time with us today. The tips you gave us were so practical and useful. I'm sure a lot of people that were kind of nervous about edentulous cases are going to have a lot more confidence now after they've seen this maybe once or twice. So thank you all and everybody, and be well.
Always good to see you, Steve. Thank you.
Bye.